Okay, we're going to get started. Thank you, everybody, for joining us for session 2 in the New Jersey Advocates for Aging Well Housing series. This session, we're going to talk about getting help in the home. So we have 4 terrific speakers today. We have Larry Aronson from Homewatch Caregivers of South Orange, Lori Morell from Parker at Monroe Adult Day Center, Edgar Brisbon from Silver Lining Advantage, and Kani Burgos from the Lutheran Senior LIFE program at Jersey City, who's going to talk about the PACE program. So first up, we have Larry. Let me bring his slides up. Okay, Larry, do you see your slides?
I sure do.
All right, I clicked the right button. Take it away.
All right. Good afternoon, everyone. And thank you, Cathy, for organizing this whole program. And thank you for allowing me to participate. I really appreciate it. Cathy asked me to kind of give she called it Home Care 101, a brief understanding to make sure that people get a sense on the basics of having somebody help in the home. So that's what we're going to try and do here. First question, and we did this in a series of question and answers. So the first question is, what is home care? It's not taking care of your yard for purposes of this discussion. So I broke it into a couple of different steps that might help you understand it. First off, who generally uses home care? It's primarily the elderly and the disabled. What do they do when they come to your home? They take care of what are called non-medical ADLs, activities of daily living, and we're going to talk more about that specifically in a slide or two, and or provide, in some cases, just companionship for the lonely or people who are on their own. In New Jersey, who provides this care? This care is provided in New Jersey by a certified home health aide. New Jersey is one of the more highly regulated areas in the country for this, with one very specific goal, and that is to make sure to provide a safe support system for those people that choose to have home care in the home. So we have higher standards than pretty much any other state in the country for who gets to do this work, and they are by title certified home health aides. What is a typical duration of a visit in a home care universe? It varies. It varies by the need of the individual, but it's typically, as little as 4 or as many as 24 hours in a day. That 4 used to be a lower number, but the marketplace has shifted, and the ability to get people to come into the home for very short periods of time is really quite limited. So in practice today, it can be as little as 4 hours several times a week, or as much as 24 hours a day. Here's a very important distinction, and we're going to look at home care in a second versus home health care. And that is the duration of service. Typically, people that are looking for home care are looking for somebody that is probably going to need that home care for the long term. Some cases not, but in general, it could be months, it could be years, it could be the rest of their life. This is not a short-term solution for specific issues, which we'll talk about again in just a minute. And finally, the role of insurance. And I know Edgar's going to talk more about funding for things like this, but in home care itself, there are really very limited insurance coverage of home care. Cathy, you want to give me that next slide? So people hear home care and they also hear home health care. And they tend to think of those two things in the same light, or really not understand that there is a distinction between those things. So I thought it very important in trying to help people understand what home care is, to differentiate it from home health care so that you understand what it's not. And I use the same set of categories down the left-hand side. So primary users, who uses home care? Primarily elderly and disabled. Home health care, all ages, based on medical need, frequently post-hospital or post-surgical, could be very short-term in need, prescription-based, and we'll get through some of these other things. Who are the primary providers, or what are the primary services they provide? Again, the home care is this non-medical activities of daily living, or companionship. A home health care agency, which many of you may have heard of, VNA, for example, Visiting Nurse Associates, that would be a home health care agency. What they're really good at is they provide skilled services. They have nurses, they have therapists, they have occupational therapists and physical therapists who come and provide those kinds of services to people in the home. As I said, frequently that would be post-surgical. So if you had a procedure in a hospital and we're going home, even if you've gone to a rehab center, we're coming home and you want to make sure that you continue to do the right things, or there are services that you need, a home health care agency or a home health care provider would be the right person to provide those skills, as opposed to the home care agency, where our employees are not skilled to be able to do things like wound care, like physical therapy, not in their skill set. Again, who provides that care? Home care, generally the certified home health aide. Skilled care, home health care, a skilled provider, a nurse, a physical therapist, an occupational therapist, somebody who is specifically trained to provide that support to you in the home. The duration of the visit, as I mentioned earlier, in a home care setting, it's frequently a long-term with as much as 4 to 24 hours a day. That's not the case in general for a skilled provider coming into your home. If that nurse is coming in to do wound care, for example, or catheter care, or some other particularly skilled item requiring support, they're not going to be in the home for a long period of time. They're going to take care of their specific assignment and they're going to move on. So somewhere between 30 to 60 minutes. How long does this service typically last? As I mentioned earlier, for home care, this could be a very long time because this is based on a life stage. This is when you need this help. Home health care, the goal is to discharge you, to provide this service for the short term, not always, but in general, to provide this short-term service short-term until you no longer need it. And they get the privilege to discharge you as one of their patients. The role of insurance, very limited insurance coverage for home care. It's unfortunate, it's sad, it's horrible, it's a terrible statement about the care that we have taken to provide for our seniors, but it's a fact. Very limited coverage for home care. Very different when you come to home health care. If you are having a skilled provider in a home, that is usually going to be covered by Medicare or some other health insurance. So again, I think you can see these are two very different things with a very similar name: home care versus home health care. And I'm discussing today home care, not home health care. So, mentioned several times the term ADLs, activities of daily living. These are the things that home care agencies or home care providers are trained to provide for you. There are generally 6 accepted, or if you look at any given list, there might be others, or some of these might not be there, but generally the accepted activities of daily living are toileting, bathing, dressing, eating, ambulating, and grooming. And I think you would all agree that these are things that you do every day, activities of daily living. And many times, though, you need help with those activities of daily living. You are unsafe, you are unsure of yourself or lack confidence getting into a shower, concerned about the number of falls that are reported happening in the bathroom. You're unable to get your clothing on properly for whatever reason. Getting around may be hard. Okay, so these are things that are considered activities of daily living. They are differentiated from other more commonplace activities like making the bed or household cleaning ideas or things like that frequently home care agencies will provide, but those are generally not the things that cause somebody to need a home care agency. Again, just as contrast, what are skilled services? A post-surgical follow-up visit, maybe they're checking for vitals to make sure blood pressure is remaining constant and oxygen levels are good. medication dispensing, wound care, pretty much anything involving needles. Home care agencies and home care providers are generally not allowed to do anything involving needles. Catheter care, physical therapy, occupational therapy, again, just to differentiate when we're talking about home care, we're really talking about the things on the left, plus what I would call companionship, okay? Somebody there just to make sure mom is safe and has some activity during the course of the day. So for example, a person with dementia might really not need help doing these activities of daily living on the side, but they're really unsafe being alone, and they really need somebody to interact with in the course of the day. Those are the kinds of things that home care is providing. Some general kinds of questions. What are some of the indicators that would suggest that I need help at home? Well, there's some that are very obvious, okay? When the crisis happens, we get calls that really in general fall into the category of, oh my God, the crisis happened. I came in, I went to visit my mom this morning and she was on the floor. She had been trying to shower and she fell down. Very, very common. So what are some of the indicators? Well, you as a family member, if that's your situation, need to watch for when are you starting to get either uncomfortable that mom or dad is safe and you're concerned about that, or you're getting so brought in that it's affecting your life. Okay, very, very common. We get two kinds of phone calls frequently, most commonly. The first is the crisis has occurred and I need help. The second is the crisis hasn't occurred, at least not for mom. The crisis is me. I'm overwhelmed. I've got more to do than I can handle. My family is suffering. I can no longer let that be the case, and I need somebody to come in. So in terms of some of the indicators, there's really two kinds of indicators. One, when something specifically is happening that you're uncomfortable with, i.e. your mom with dementia is found out on the street, walking in the street, or your mom has fallen and more than once, and maybe even tried to hide it because they don't want you to know. So they are very likely to say, oh, I just bumped myself, trying to resist this need to have help, or as I said, you become overwhelmed. What kind of options exist? Well, I've been talking about the options in the home. There certainly are other options that allow you to continue to have your loved one live at home. We know the statistics. 90% of people want to remain in their home. So home care is one way to achieve that. There are other options. We'll be talking about adult daycare in just a few moments. That's another kind of option that allows you to get some level of support so that you're in a better position, but you still have mom living at home. Can an aide support both my parents? Certainly. That's an arrangement that you make with a home care agency should you have one come in. Costs more money, but certainly there. I love this one, this last point here. My mom is super comfortable with the woman who cleans the house. Can I just hire her to take care of mom? And the answer is certainly you can, but there's a consequence. Cathy, you go to the next slide. This may be the most important slide that I share in my couple here. Should I use an agency or hire privately? There are many, many great examples of hiring privately and having it work out perfectly. So I'm not going to suggest that that can't work, but there's some significant pros and cons that people should appreciate before making that decision. So I tried to break this out. Hiring privately. Pro, it is less expensive, 100% less expensive. Pro, a perceived higher level of control. You're in charge, okay? But the cons, there is no skill set verification. There is no background check unless you're going to execute that. It's likely that the person is not bonded or insured for this type of work. There's no supervision to make sure they really understand that what your family member needs and what they're able to provide. Really importantly, there's no backup. It is not unusual for somebody to hire privately and have things be going wonderfully well until the phone call comes. My mom in Jamaica just passed away. I'm going home tomorrow. I don't know when I'll be back. There is a whole required effort to be legal if you are hiring privately, whether, for taxes and purposes like that. And one that people really underestimate the significance of is no workers' compensation. Workers' compensation is really, really important, because if you don't have it and you haven't hired somebody legally, they don't even have to get hurt. They just have to say they're hurt. And you've got a big challenge on your hands. Hiring an agency in New Jersey, there's state supervision of agencies. There are very specific hiring requirements. There is a nurse who's involved in supervising that caregiver. There is backup support. That's part of the obligation an agency has. There is problem resolution. Things aren't going exactly right. That doesn't mean you should start over. That just means you need a trained professional to provide the right kind of support to see if that problem can be worked out. Properly insured. You and the caregiver are properly insured, and you are compliant from a regulatory standpoint. The con, it is more expensive. No ifs, ands, or buts about it. So that's the trade-off. So again, I don't tell people that they can't hire privately, but I want to make sure people understand the risk when they do. Next slide, my last slide actually. So if I decide to use an agency, how do I get started? So I did this as a do's and a don'ts. Do's, do some homework in your community. Your family friends, your medical community. Ask around in your location, ask around. There's a good chance that people around you have some experience. Make a list of no more than 3 agencies, no more than 3 agencies to really get to know. Look for some external validation, awards, reviews, personal recommendations for that agency, etc. Prepare for yourself a list of questions that are germane to you and that you want to make sure you understand. And then call those agencies and speak to, they may have different titles at different places, a social worker, a case manager, a variety of different things. Speak to the person who's responsible for intake of new clients and ask them your questions and keep track of the answers to those questions. Once you've done that, ask for somebody to come to your home. If they don't want to come and meet and see the circumstances, I would stay away. You would expect them to want to get an understanding of what they're being asked to do. Evaluate these 1, 2, 3 agencies all the way through the process. Did they answer the phone promptly when you first called? Was the person on the phone able to handle your questions? Did they get you to the right person? When they came in, were they professional in nature? Did they give you the information you needed? Evaluating all the way through the process. And then at the end of the day, hire the agency, not a caregiver. This is a real challenge for us as agencies, but one that we really feel strongly about. If you do the right homework, you want to find an agency you're comfortable with, the different people, and then be able to expect them to help you through the process. Some of the don'ts. Don't look for the cheapest agency. Okay, just, you get what you pay for. Don't try and talk with too many agencies. There are a lot of good agencies out there. Find a couple that you can talk with, and I can assure you, you're going to find one you're comfortable with. Don't demand to interview the caregiver. Ooh, this one throws people a little bit. Why would he say that? Okay, it goes back to what's on the bottom of the first column. Hire the agency, not the caregiver. I can't tell you how many times I've heard about caregivers going in, winning a case with an agency only to suddenly be not the caregiver that shows up the next day. Okay, or even a well-intentioned situation. Caregivers come and go. Family situations, lots of different reasons. Well-intentioned agencies may have you meet a caregiver, you fall in love with the caregiver, and the caregiver calls the next day and says, you know what, I'm not really interested in that case. Or, you know what, something's going on with my mom. or I just got another job from somebody else. So I'm out of here. And now you feel like the agency's done a bait and switch. And it may be without anything done on their end. Don't look to change agencies the first time there's an issue. We tell people it is quite likely that despite all of our efforts to get the perfect match, that we're not going to be successful every time. That doesn't mean we're not going to be successful. So work with the agency that you've chosen. Let them get it right. Give them an opportunity to get it right. And don't expect everything to be fantastic. This is tough stuff. You're putting somebody in someone's home for an extended period of time, and everybody brings baggage to that equation. So to the degree you acknowledge that and know that this is a process, you can have a really, really great experience. So I think, Cathy, that's my last slide. Hopefully that gives you some little perspective within my time slot on Home Care 101. And I'll be here through the session. At the end of the day, I'll be able to answer any questions that you might have.
Thank you. I have a couple of comments and questions in the chat I want to put out to you now. And if you are raising your hand, I can't access or give people the ability to speak. So if you have a question, please put it in the chat or in the Q&A. That's the best way so that the panelists can see it and answer it directly. But I want to thank Sam Krause pointed out that in the Medicaid world, home care is called PCA, personal care assistance. And it's in New Jersey, it is covered as long as it's deemed medically necessary. So that is important to know.
Yes, I knew that correction. That's right.
And then there's a comment too from Donna Plotnick that if the aid is paid under the table and good records are not kept, it can affect the ability to get Medicaid later on.
Huge point.
And there are some other comments in the chat for people to look at, but we will also get back to those later at the end of the session. So now we're going to move on to Lori Morell from Parker Life, who is going to talk to us about adult daycare, which is something she and I have spoken about. It's something that's probably not well understood or well known about, especially here in New Jersey. So Lori, please enlighten us.
Thank you so much, Cathy, and thank you for giving me the opportunity to inform people about adult daycare, an option for older adults that are living at home. I am the program director for the Adult Day Services in Monroe Township at Parker Homes. And if you could just, let's go to the next slide. Thank you. So everyone wants to know, what is an adult daycare? Adult day programs provide care and companionship for older adults who need assistance or supervision during the day. And I can elaborate on that by saying engagement. I think engagement is the word that we really need to focus on, because people should never be bored. And unfortunately, after 2 years of COVID, we know that there was no toolkit to manage the outcome from that for our seniors aging in place. Supporting the independence and well-being of elders living in the community to improve their quality of life while aging at home. If you could go to the next slide. Thank you. Coordinated program of professional and compassionate services. Let me expand a little bit on that. So when our participant comes to an adult day center, we are not only welcoming our participant, but we are welcoming the caregiver as well, because we are serving two purposes. We are helping the caregiver get some respite, and we are also providing an environment for the participant to engage with his peers and also have socialization and feel that he has a purpose in life. This is a tremendous opportunity for seniors to stay connected to their peers. It's very nice to have somebody in your home and taking care of you. And I think it works. Some things work for some and some things don't work for others. But if I put a 15-year-old with a 30-year-old, there's really not too much of a common denominator there. Another thing that you're going to find at the Adult Day Center is recreational and social activities. So there is a recreation therapist that is on board planning daily activities to engage the elders, to have them participate, to stimulate their brain, also stimulate their physical being. So, and they both work together. And then, of course, it's a mindset. So you're now actually you're being a little bit more mindful on dealing with the whole person, not just one piece of the person. And this is supported by nursing assistants, recreation assistants, social workers. It's also a supervised care in a supportive environment. What does that mean? It means that people come to us from various cognitive and physical levels, and we're able to support them with their ADLs. Maybe they need some support going to the restroom. Maybe they need some medication administration. Maybe they need some cueing or prompting, but they're still functional and they still have a purpose. And actually that's an Eden principle, which means that as we're aging, it's just another chapter in life, and we should still all have a purpose and feel valued. And again, we go back to that caregiver respite piece. Very important, because after those 6 hours, the caregiver and the participant are then together for whatever period of time it is. And it's very taxing on the caregiver. It's kind of the sandwich population that we're in, where now we have the parents living with the children, and the children are taking care of the parents, and they have to go to work every day, and they're worried about their loved ones. And how do we provide a safe environment and also a healthy environment for both parties, because we're dealing with several generations living under one roof, and it can be a little bit taxing at times. You could go to the next slide. Thank you. So again, nursing supervision and assessments. So we're able to accomplish that by having an RN on site at all times. We cannot even open up our facility without an RN, because we're a state registered facility. We do assessments on the cognitive and physical needs of the participant before they're admitted to the program. And the reason for that is so that we are able to then decide what is the best approach on how we can engage this person and stimulate them and give them the best possible day. And so part of that would also be with our social worker. So we have a full-time social worker. And what they do is they actually have a conversation, not only with the participant, but with the caregiver, to understand what their needs are. What do they like? What was their pastime? What did they do most of their life? So this way, that's another communication tool that we're able to reach out and support them with their group activities for the day. Again, being able to facilitate medication administration, and again, the ADLs, whatever they may be. And everybody is different. Everybody is individualized. We can also give them therapeutic recreation, socialization, and group activities. And so we can do that through entertainment. We may bring in entertainment. We may do arts and crafts. We may be doing group exercise. We may be doing personal training. We are very fortunate to have our own personal trainer on site, which is included with the membership. We may also do different kind of a stimulus, where we have people come in and do maybe pottery or gardening, or we have a horticulturist who comes in. So we really do try and find an opportunity for everybody that enters our program. And then we have case management and a care coordinator. So we work with various care coordinators from different medical denominations. So such as the social workers may be at a rehab site that may want to recommend their client to us, or their physician, a geriatrician, would have maybe a case manager, and they would find an outlet for their client, and they would recommend us. Then, of course, also we have on our particular site, we can provide physical, occupational, or speech therapy. And that's done during the course of the time that they're here. So we can support the families with not having to worry about transportation. We can manage that self-care here. We have salon services right on site. So they would be able to have salon services. Everybody wants to feel good about themselves. And that's also part of just having, taking care of oneself and feeling valued and deemed. And transportation. So again, there's transportation. We are able to provide transportation for people who are possibly parents that are living in the home, transportation to and from our facility, because that seems to be a big problem with seniors today, or people who can no longer drive, or people who are disabled. We have that advantage and that ability. If you could go to the next slide. And so let's give you a little sample of socialization. And I'm going to speak from personal research that we happen to have done at Parker with the University of Pennsylvania about socialization with the elders and people who have not been socializing. So our research has shown that social interaction has many benefits. We know that people that are socially more active improve their mental, physical, and emotional health. And because when you're eating with people, and we know that as adults, that's when you have your best socialization, right? So not only are we able to socialize during our meals, but we're giving people a nutritious meal. And it really may be the only nutritious meal they receive during the day. But going back to that research piece, so the outcome of that research piece with the U of P showed that people who were socially isolated for long periods of time suffer from more depression and generally mask itself as dementia. Now, after 2 years of COVID, unfortunately, and being socially quarantined, we are seeing many more seniors who are experiencing dementia at this point, from having no stimulus, no engagement, no conversation, no interaction with other humans. Very sad outcome. If you could move on to the next slide, thank you. Benefit to the caregiver, that's the biggest benefit. For caregiver, an adult day program might be good for both of you. We have, here's a little testimonial. My husband loves the program. He really feels energized and it gives him purpose. And this is Doris, one of the participants' wife. And I'm going to give you a few other examples of the good fortune that we've been able to have here at my particular center. That when they want to come for the first day, what happens is they want to come back. And so that speaks accolades about what you're giving back. So our caregiver support services, and this is the idealism behind Adult Day here. When we admit one person to the program, we really admit two. Our staff provide education, empathy, counseling, and compassion to the caregivers. They need such support. There are times when it's not only respite, but we need to give them the direction on how to handle behaviors. Everybody handles behaviors differently, and it's different for everybody, and no one dementia is the same. And so being able to have that ability to have insight into how to support other people and have them know that it's going to work for them. And I'll give you an example of something. We had one particular caregiver who had, their loved one who was OCD in the shower, and he would be in the shower for 3 to 4 hours. And so we recommended that what they should do is just give them enough shampoo and soap to wash their body once and wash their hair once. And that really was the answer to the problem. And so sometimes we have to go through those loopholes and figure out what the solution is. We don't really see it as a problem. We see it as it's a new avenue, and how are we going to try and find the solution to support the caregiver, but we're also supporting the participant. If you could move on, thank you so much. Mental health. This is a huge part of it. And we know from our own personal perspectives what the past 2 years has done, because nobody gave us a toolkit for managing COVID-19. Consistent human contact and interaction can reduce depression and dementia. Those who engage socially improve mood and quality of life. Studies indicate that social and physical activity may be less likely to develop dementia. So we know from socialization, and let's put that physical activity piece into it, that is really important. We know lack of physical activity does not promote serotonin to the brain. So serotonin is that endorphin that makes us feel happy. And that's basically what's in antidepressants today. And we know that a lot of seniors are on antidepressants. And the reason they're on antidepressants is they may be socially isolated, they're not moving, and we know lack of movement actually promotes falls. Falls promote fractures and breaks. And then, of course, rehab, and then we have the increase of dementia and depression. So it's a vicious cycle, and we need to support our elders. You could turn to the next slide. Okay, improve physical health. I'm always a little bit ahead of myself. I apologize. But people who find ways to interact socially live longer than those isolated. Relationships and social interactions help protect against illness by boosting the immune system. Now, we know that. We know people who have relationships live longer. We know people who have family live longer, and they're not isolated. So that's so important. And it's about the person's whole self. People who go to church. So what happens, say you fall and break your hip. So now it's changed your entire life. It's changed your independence. It's changed the things that you like. And I see a lot of questions coming up, and we are going to address those. They're coming up, but thank you so much. I just want to share that. So we need to help with that part of it. So if you could go back to the next slide. I'm going to move on. So here's our typical profile of somebody who's in our program. Somebody that may be diagnosed with dementia, Alzheimer's disease, frontal temporal dementia. These are different kinds of dementia. Not everyone is the same. Young onset adult dementia or Alzheimer's disease, Parkinson's disease, vascular dementia. So dementia comes in a lot of different forms. And Parkinson's disease, you get something called Lewy bodies, where you have these plaques. And that's also part of dementia. Then we see people with mental health disorders, schizophrenia, clinical depression. So these are people that don't have harmful behaviors. We do not accept people who have aggressive behaviors into the program. I just want to differentiate. Medical conditions, MS, multiple sclerosis, so spina bifida, diabetes. So people who have these are still cognitively intact. They just may have physical impairments. And believe it or not, that there's a common denominator. And I always say, not one thing is made perfect in this life. And so there's disabilities in everything. FTD is frontal temporal dementia. So that is a very, very stringent form of dementia. That's probably the worst dementia that you can have. It's a form of Alzheimer's and affects the frontal part of your brain. And it's a very quick, debilitating form of dementia. And dual diagnosis. A lot of people come developmentally disabled. They may have some disabilities. And then what happens with that is they also develop dementia in their later years. And then, of course, we have a social program. Somebody that's socially isolated or have something called MCI, mild cognitive impairment. Means they're functional, but they may be forgetful. They may repeat something. That doesn't mean they're non-functional, and they're not approachable, and they still don't want to enjoy life. So that's a social program. We do blend both. We are able to actually support medical and social pieces in the program and the participants. If you could move on to the next one. So we're going to talk about funding. A lot of people, that's the first thing they want to know. So many affordable options for seniors. A lot of people just don't know about what's out there. County offices have something about disabled and aging grants. Every county has different grants. I'm going to tell you that in the state of New Jersey, the two counties that have the largest amount of funding are Bergen and Middlesex County. I happen to be in Middlesex County. We have tremendous funding for seniors and the disabled. Medicaid, this is huge. People who are in Medicaid or managed care are able to get reimbursed or subsidized through their managed care. I will tell you some of them that we work with that I know have managed care. Horizon Blue Cross Blue Shield, United, Aetna, and WellCare. So we can do single party contracts with them and actually get days paid for medical participants through that. And I have several people that come and they actually get funded. So they can come 2 or 3 days a week, no charge back to the family, or there may be a small copay. The Alzheimer's Association has a program that is for the adult day population, depending upon your your Social Security, whatever you get monthly, and it's based on the criteria of your financial assistance. I have several people that come 5 days on this program and have a copay. Now, am I going to tell you the copay is the same? No, the copay is different depending upon where you fall on the sliding scale. So, and for an example, I have somebody who pays $15 a day as a copay and for 5 days a week. So for $75 a week, she can come 5 days a week. I have another person who pays $7.25 a day, and that is her copay. So everybody is different. There's different, it depends upon the criteria and the sliding scale. That's where the social worker or myself would get involved to create that grant funding. We have the VA. So people who have been a veteran, actually who fit the criteria, who have been in the VA regularly, who get assessed by the VA, are entitled to 2 days per week once they are approved by the VA. That is funded 2 days per week for all our VAs. Not every home is VA affiliated. We are VA affiliated. I do have a lot of veterans here. And then, of course, long-term care insurance. If you have long-term care insurance, the long-term care pays back once assessed, depending upon your ADLs or your activities of daily living, on what they're going to pay. So transportation. Transportation, depending upon what facility you are going to, they decide the transportation ability. So I'm going to also say, depending on the county that you're in, different counties have provided transportation for their seniors. So the ride can be $3 each way, which is $6 a day for transportation to an adult day. We provide transportation for some of the people that do attend our facility. And you could go on, and then I can answer any other questions that you may have. I think that's my last slide. Okay, so here we go. There's my last slide. We have 3 centers. 2 are right now high up in operation. One is located in Highland Park, and that's by Edison, Somerset, Piscataway. I'm in Monroe Township. We're going to be opening our Somerset facility in 2022 for people living up there. And you can see our video at Parker Life or visit us on our website.
Okay. Lori, thank you very much. And I see that most of the questions, I think you answered most of the questions that came up. which started relating to payment. So we're going to turn it over to Edgar to talk more about how to pay for these options for home care. I just have to find your PowerPoint slide. Just give
Well,
me a moment.
I'll
Yeah, I
answer
love-
Deborah that we are open for tours right now and assessments. Mhm.
Well, and if you
Thank
can't
you.
find my slides, I'll just start talking. That's perfectly
There
fine.
we go. I think I found it. You can start talking while I take it up. And this is going to take me a moment. So
All right. Well, first of all, I want to thank Cathy and NJAAW for asking me to join you. I'd like to also thank the previous presenters. Quite frankly, there was enough information that was going on between them, and I believe it's Joseph, that I probably wouldn't have to say anything relative to all this. But I'm
yes,
still
thank
gonna
you,
try to
Joseph.
Yeah, thank you, Joseph. We'll pull you on for the Medicaid part. One of the things that I'll say to you that I think is important when we're talking about preparing for in-home care is to have a plan. When I work with clients, having a plan is always critical. There's certainly been enough surveys out that have talked about in-home care and the fact that the majority of respondents, probably 90% in the last survey that I read, prefer to live out their life at home. But one of the best surveys that I read had a follow-up question, and that was to ask those individuals who wanted to reside at home what kind of planning they'd done in order to make that happen. And that 90% of those respondents went down to 20% in terms of people who had taken the time to either make sure their home was appropriate for care and that they also had some kind of funding source. In the insurance industry, certainly long-term care insurance industry, which I know very well, I'm a licensed insurance agent only selling long-term care insurance. What we say is that if you haven't figured out a funding source for assistance, whether it's in home or in a facility, then you basically opened up everything that you own as a source for paying for care. So it's really important to understand, as I like to think of it, the what, where, who, and how. What kinds of services that are needed in terms of assistance, which Larry has spoken about, where it is those services are best rendered. And while again, home is in most cases the preference, it may not clinically be the most appropriate place, who it is that you want to render that assistance to you. And more importantly, not more importantly, but certainly the piece that I'm talking about is how one pays for that care, because that's a very critical thing. In most cases, in-home care is paid privately. It's private pay because there are limited sources, and we'll certainly talk about Medicaid in a few minutes, but there are limited sources outside of that that pay for care. And individuals end up paying for care in one of several ways. If there's available income, that is income beyond the cost of maintaining their house and their living expenses, that is shaved off to pay for care. We end up tapping into savings accounts to the degree that that exists. And then there's a larger issue of the liquidation of things that you own. I say liquidation, perhaps people are more comfortable with the word usage, but the bottom line is it's liquidation. And by assets, I mean brokerage accounts, investments that you might have, IRAs as well. The problem with those two, talking about brokerage accounts and IRAs, is that number one, there's an issue of taxation, because typically distributions from those are taxed depending on the kind of account that it is. And there's also a timing issue. So, and by timing, those of us who remember 2008, whatever your account looked like in March of 2008, it certainly didn't look like that in November of 2008. So if in fact the need for care and the need for that funding occurs at a time when we're in a down market cycle, you may find that you have far less available to you than was anticipated. Beyond that, there are, and again, I'm just talking about the things that one owns that may be leveraged in order to pay for care. The life insurance industry has a number of programs that have been developed. There's a life settlement. These are generally for policies that are in excess of $100,000, where there are companies that will purchase for a lump sum your life insurance policy. They'll pay you a lump sum, clearly much less than what the death benefit is, but it gives you access to those funds to use in a way that you need in order to pay for care. Beyond that, we start talking about things like the leverage of the equity in your home. And that occurs either in a reverse mortgage or in a home equity loan. Many people have tremendous problems with that because it obviously impacts on your legacy. It impacts on a community spouse, as you referred to, that is an individual who may not need care, who's living in the home. So to tap into that level of asset has a sort of downwind effect for those other folks. But again, if you have not identified a clear funding source to pay for care, everything sort of ends up on the table. And so these are several of the ways that one will pay for care privately. Next slide, please. Then we have the issue of insurance. And certainly a couple of people have referred to long-term care insurance products. Quite frankly, I'm very high on long-term care insurance. I've had my own policy for about 15 years. I became a life insurance, a licensed agent because I thought it was the greatest thing since sliced bread. That said, there are a lot of issues that we've heard about in the public sort of discourse about long-term care insurance. The primary issue that people discuss is the issue of the price. For me, my focus is less on the price of insurance and more on the price of care, the cost of care. And long-term care insurance is a good way of leveraging against that cost so that you're no longer paying dollar for care. The secondary issue of long-term care insurance is that you need to get it when you're younger. And by younger, I mean in their 50s. There's some language that you'll see that talks about receiving or purchasing long-term care insurance in your 60s. I have two issues with that. One, as you get older, roughly about 3% a year in terms of age, the price goes up. So what it costs for you at age 55 and what it costs for you at age 65 is dramatically different. The other issue that we don't like to think about is as we get older, even though we may consider ourselves to be healthy, there may be conditions that you're certainly able to live with, but that also make it difficult for you to be approved. Long-term care insurance policies are underwritten medically so that you need to, in fact, be able to pass the criteria in order to get long-term care coverage. But that said, it is still one of the better ways, in my opinion, to pay for it if you have the ability to meet the premium cost and to meet the medical criteria. I touched a little bit on life insurance. We swing back. Ways of using life insurance. Obviously, the larger the death benefit, the better. The kind of policy that you have is important. For those people who have whole life insurance policies, without getting into sort of life insurance 101, but a whole life insurance policy accrues cash throughout the life of the policy. That cash can be withdrawn, it can be borrowed, or you can actually surrender the policy for the value that's in the cash portion of that policy. It is one way of paying for care. And again, the larger the policy, the more cash value you have, obviously the more value it has to it. There are life settlements, which I touched on before, where there are companies, and again, these are particularly for larger policies. There are companies that will purchase your policy. They will maintain the policy and give you cash for it. The cash can then be used in whatever way you need, whether it's making adjustments to the home or paying for care. And there's a growing option, which is called life care funding, where basically a company purchases your policy and they provide money directly for care. That is, they don't give you a lump sum, but they pay it out over a period of time to the care providers. Also, kind of in the long-term care insurance market, there's this thing called accelerated benefits on life insurance policies, where you basically purchase a life insurance policy that allows you, once you meet the ADL requirements, Larry touched on that a bit, I'll touch on it again, is that it will accelerate the death benefit over a period of time. Generally, that's about 4 years, where they'll pay you out the value of the death benefit on a monthly basis. It's done as an indemnity so that that money comes to you directly as opposed to you're having to submit bills, et cetera, for that. And that money can then be used in whatever way you need it, but most certainly for care costs. So in all of these cases, we're talking about there being an ADL requirement. And what that basically is you need to have a substantial assistance with 2 or more of the activities of daily living. Larry presented certainly a list, and we'll talk about that a bit further. The last 2 are Medicare related. And I list those not because they're a good way of paying for in-home care, but because it's a question that always comes up. And part of the confusion, I think, certainly with older individuals who probably remember a point in time where Medicare paid kind of a fee for service for certain kinds of activities, well, it really doesn't do that anymore. And the second piece is that when you look at the Medicare handbook, it makes reference to long-term care services, but those are primarily skilled care needs. So that if you have been hospitalized for a period of time or have a particular illness, with a prescription, you can get in-home health care. And in addition to that in-home health care, you get some limited home care services. But I really do mean limited, so that I've seen people for whom a home health care aide will come out once a week for 6 weeks to provide a particular service, like giving a bath, et cetera. And in this world, as we're talking about long-term care services, one of the other terms that's used is custodial care. And that is people who need assistance on a daily basis with their ADLs, but who do not necessarily need medical intervention or skilled care. So Medicare does not pay for custodial care. Medicare Advantage, for those of you who watch television, far too much with all these crazy ads about, calling in with Joe Namath and whoever the heck. There are a couple of Medicare Advantage companies in the last couple of years which will say to you that they offer home health care services, but those services are only offered in conjunction with skilled care when it's needed and when there is a prescription for that. It's generally for a limited period of time, 6 to 8 weeks. And again, the benefits that are available are relatively limited. So again, I list the Medicare issues really because probably every other week I get a question as to, doesn't Medicare pay for this? And the bottom line is that outside of skilled care, it really doesn't. So the other consideration for people who are veterans is that there are a number of veterans programs that can assist in paying for home care, or at least providing money for home care. Probably the most best known one is aid and attendance, which in effect is a veteran's pension that provides up to the dollar amounts that you see on the screen, because it is somewhat complex in terms of the application process. It really depends, veterans benefits really depend on the war in which you served, your discharge status, the amount of time that you were in service, at least 90 days, one of which has to have been within an approved war. Not sure that's a great term, but that's there are certain theaters for which there is coverage for A&A and ones that there are not. And so these are benefits that are the pension. The aid and attendance is a pension that, if you jump through all of those hoops, can provide dollars to, in effect, keep you from falling into poverty. It's really considered a safety net. So it's looking at your income, it's looking at your assets. Generally, they will not look at an application if your assets exceed $80,000. And it is money to offset the expenses for in-home care. They also, if you're receiving your health benefits through the VA, they do have a homemaker and home health aid services as well as skilled care services. Again, all of those have specific criteria as it relates not simply to the need for care, but in terms of what your assets and your income are. So those are worthwhile things to look at if you're a veteran, certainly if you're the widow of a veteran, as potential ways of paying for care. And then the next slide. So this is where we'll put Joe on the screen. Public benefits really fall into a couple of categories, and certainly we'll hear about PACE a little bit later, so I'm not going to spend much time with that. But Medicaid managed long-term services and support, which is what MLTSS stands for, is a potential benefit for those who meet both the clinical and the financial criteria. And it's a piece that folks sometimes miss. It is both. It is not simply that you need assistance. It is not simply that you don't have money. but you have to meet the appropriate criteria for the waiver program in both cases. What I say to folks frequently is that Medicaid is a safety net program. So it's primarily there for individuals who have limited asset, limited income, and have no other way of managing their care. It is a worthwhile program. There are hoops to jump through in terms of the financial information needed that has to be provided. Generally, this falls into a look-back period of 5 years, particularly when we're talking about facility care, where 5 years worth of financial information needs to be provided. You need to explain expenditures over a specific dollar number. But it is a worthwhile program if in fact you've spent down to the asset and income asset levels and have limited income. A less known plan, which is not a Medicaid plan, is JAAC, and that's the Jersey Assistance for Community Caregivers. The criteria for JAAC is a bit higher in terms of the financial requirements than are the Medicaid criteria. For someone who is participating in the JAAC program, they have to have assets below $40,000, significantly higher than if you're going through the Medicaid program. It's $60,000 if you're a couple, and your income, the maximum income is $4,100 a month. It's actually $4,134. So JAAC is an option for individuals who perhaps have too much assets or too much income. The JAAC program, again, has to be clinically verified. They do an assessment to determine that there is a clinical need for the services that are provided. And if you're at the higher level of the income, there may in fact be a copay that's required for the services that are provided. So JAAC is an option. One of the issues that I have, particularly in New Jersey, is that both through MLTSS and through JAAC, it is difficult to get 24-hour-a-day service. And in fact, JAAC, which is easier to apply for, limits the payment for in-home care to about $761 a month. And you certainly can do the math as to how far that goes. But again, if that is sufficient, if that's what you're going to become eligible for, it's a worthwhile program in conjunction with things like adult daycare or informal care that comes from family members. Once again, in all these cases, there's the issue of the ADLs. When we start talking about public funding and we talk about coverage through insurance, then it's a matter of you're needing assistance with 2 or more of the activities of daily living. I think there was an additional slide, Cathy. And one of the things, the only reason why I raised this is there are really 2 sets of activities of daily living. The one that is currently on the screen is really referred to as the instrumental activities of daily living. I put this up because when you say ADLs, this is usually what people think about. You know, these are things that are related to assisting someone to function independently. But from a clinical perspective, it's the functional ADLs, which is the next slide, which are what's required in order to qualify for the kinds of services, either through insurance or through public funding or through the VA for that matter, that we've spoken about. So these are really issues where someone needs assistance with their personal care. And as I point out, just as an example, we talk about eating. Eating is not about being able to cook or being able to shop. Eating is about being able to get the food off the plate and into your mouth and to swallow it without difficulty. So these very clearly I like to refer to as functional activities of daily living. And this becomes the criteria that one looks at in determining whether or not you're eligible for services under either public benefits or insurance-based benefits. And as Larry pointed out, the last one, cognitive impairment, you may be able to actually do all of those previous items. But because of a cognitive impairment, be that memory or processing, you need prompting, you need support, you need for folks to be around to make sure that you are safe and not wandering off. So the cognitive impairment, and the reason why it says or cognitive impairment is if you have a diagnosed cognitive impairment, the others don't really matter. That is kind of a standalone ADL requirement that would basically make you eligible for services as we've discussed. So I don't know how I did on my 15 minutes. Unfortunately, the part of how you pay for care is really pretty straightforward. Complicated, but straightforward. So that's my presentation.
Thank you very much. And we did have some questions, and thank you, Lori, for answering some of them as they were coming up. Lori said that Jack covers 2 days of adult daycare. That's 2 days. How often, Lori? Is that per month or per week?
It's every week.
Oh, 2 days per week. Okay.
Yes, that's if you're approved.
Okay.
Mhm.
And when we send out these slides to everybody who registered, I will add the website or information about Jack, so people can find it. So I want to move on to Kani, who's been waiting patiently, and we put her last after Edgar talked about financing, because the PACE program really is a unique program and it's not available everywhere. So again, it's going to take me a moment to get the right slide up here, if you have patience with me. So Kani, if you want to start and introduce yourself while I get this taken care of.
Absolutely.
Go ahead.
And good afternoon, everyone. And thank you, Cathy, for having me here and talking about the PACE program, a program that I'm very passionate about. I am the Director of Enrollment and Outreach for the NJAAW LIFE PACE program of Jersey City. And we here at PACE at LIFE service Hudson County. There are 6 other including with our PACE program, in total, there are 6 PACE programs in the state of New Jersey. And at the end of the presentation, I've listed where these programs are. And, you know, just to kind of summarize what the PACE program is, because I know we're also probably running out of time, you know, it's an umbrella of all of the services that the panelists have talked about. So under the umbrella of the PACE program, it is an all-inclusive care for the elderly or those that are 55 and over disabled. And the goal of the program is to keep our seniors and our participants safely and independently living at home. We are an integrated system of care. So we are the insurance company and also the provider. So we have a network of community specialists that we are contracted with. And we're not restricted by traditional insurance limitations. We do operate under an IDT team, which is interdisciplinary team of clinical professionals. It also includes pastorals and our executive directors of the program. We are centrally located and we are in the same campus of Jersey City Medical Center. The PACE program of Jersey City has been around for about 10 years. But in the state of New Jersey, it has been around for since 1997, I believe. And I apologize if that's incorrect, but I believe it's been around since the late, 1997. We are certified to provide nursing home level of care, and that is a clinical criteria. I know the other panelists have said you have to meet certain ADLs with the PACE program. And you can switch to the next slide, Cathy. The PACE program, you have to meet 3 of the ADLs to qualify for the program. And this is monitored and approved by Medicare and Medicaid. So most of our population of participants are dual eligible, which is Medicare and Medicaid or SSI. Nationally, there is about 3% of people that pay for the PACE program privately. The rate for private pay for the PACE program is under $6,000, which is a lot less than paying for long-term care in a nursing home. And we can talk more about that, or you can ask questions. What makes us unique to the program is that care coordination across all settings. So we coordinate all of the care 24/7, 365 days. There is someone on the phone that you can talk to. We do daily calls, monthly calls, and everything is under that IDT team. We prevent and delay facility placement. That is our goal. Currently, we are under 10% of our total membership that is living in a nursing home that is paid for by the PACE program. And the goal of the program is to reduce those unnecessary frequent flyers going into the emergency room or going into the hospital. And we address all of the participant goals through IDT, and it's an individual care plan. And we provide care through end of life. Next slide, please. Our program participants are those that are 55 and over, clinically eligible to meet that nursing home level of care. So at least 3 of those ADLs or cognitive deficits. For our PACE program in Jersey City, you have to live in Hudson County within the zip codes and can live safely in the community at the time of enrollment. We can assess someone who is not living at home, but it has to be a case by case. So let's say someone has a voucher that's living, that's homeless for whatever reason. We could work with that person, but it is case by case. But the goal of the program to keep somebody living safely at home. Next slide. And during the challenges of the pandemic, Lutheran Senior LIFE rose to the challenge by providing 100% of home-based community services in the home. Because of COVID, we weren't able to have our participants come to the clinic. We weren't able to have the adult daycare open. So all of those services were provided in the home. So our providers, our doctors, our nurse practitioners, medication management, and even that social component, which all of the panelists spoke about today, was all taken 100% into the home. Next slide, please. So just an overview of the type of services that fall under the PACE program. So we do recreational activities, and we provide 2 meals per day. The Adult Day Center attendance prior to COVID, we can have all of our participants in the center. That was part of their care plan. Now we are operating at a cohort. So those that are most clinically needed to come to the Adult Day Center, those people that have cognitive deficits, are coming in more frequent. And of course, we're all struggling with home health aides. So those folks that require longer home health hours, we're able to supplement that by having them come into the day center as well. In the center, we can provide personal care, showers, and laundry services. Be surprised some of our seniors don't have proper place to safely take a shower or do their laundry. In our center, we also provide primary care clinics. So we have our physicians, our nurse practitioners, and nursing on site. We also do on-site labs and x-rays, on-site specialties, coordination like vision, podiatry. We also do psychiatry in our center, coordination of all other specialties like your GYNs, geriatric care, et cetera. We do medication management and coordination, and we do a mail delivery of medications as well. We do wound care and end of life on call, as I mentioned before. Unique to our program is that door-to-door transportation. How many times do we see a senior and a caregiver waiting outside endlessly for transportation to come? With our program, we have door-to-door transportation, and we also have a companion in addition to the home health aide, if eligible. Our home health coordinators, we have personal care, home health, food prep, housekeeping, and laundry services. We have therapy on site. So we have our gym, which is a full-time PT, OT, and speech therapy, so physical therapy, occupational therapy. We have in-home therapy for those participants that are homebound or bedbound. We also provide durable medical equipment and home modifications. So when we're going in to do that home assessment, if we identify some areas of opportunities for modification, that's something that would be part of the care plan and covered through our services. In addition, nutrition services. So we have dietitian, specialty diets, weight, diet management, and home delivered meals. We have social work services. So it's social work, psychology, psychiatry as well, case management, and housing assistance. Other services that are covered is Medicaid application and renewal, nursing home placement, respite care, audiology, including hearing aids, and we assist with the enrollment of any other community services. Next slide. So if you're interested in learning more, my name is Kani Burgos. My information, you can reach me on my cell phone, which is 201-499-3910. My cell phone is 862-217-1981. And feel free to visit us on our website. And thank you.
Thank you, Kani. I didn't mean to make you rush through that. You had a lot of really great information. And I'm going to leave this up for a little bit so people can take that down. But I just want to go back to, you said that your clients have to reside in Hudson County. So it can't be that I go to your hospital and I live in Union County or Essex County. I need to reside in that county.
Exactly.
So where else is this covered? I will put, when I send out the slides to the registrants, I will put the state website for it. But can you talk a little bit about how that's decided on the geographic service area?
Yeah,
or where they are?
So on a state level, it's identified where there is a need, whether it's a clinical need or financial need. So these programs are in areas where there are overpopulation. There's not enough nursing homes for long-term care. So I can give you, I can go to the list. So there is Life at St. Francis, and they cover Mercer County in Burlington. There's Trinity Health Life, which covers most of Camden and some of Burlington County. There's us, Lutheran Senior LIFE in Jersey City, so we cover Hudson County. There's Inspira Life, and they cover portions of Cumberland, Gloucester, and Salem counties. There's also Beacon of Life, and they cover Monmouth County. And lastly, there's Atlantic Care Life, and they cover Atlantic and Cape May counties. So it's pretty spread out. I know in that legislation, they are working on expanding the PACE program. It is an innovative model of care. It's been it started out in California in the 70s by an Asian community where, the Asians like to take care of their families at home. So this model has been adapted, and throughout the state, there's about 70 PACE programs, and this program continues to grow. Just to throw some numbers out there, for those people that do not have Medicaid yet, I know just thinking about Medicaid can be very daunting, and Mr. Edgar can, attest to that. So the income requirement for this long-term care Medicaid for 2022, the income limit is $2,532. When we think community Medicaid, your income has to be like below $700. So with this long-term care, and most people that are on Social Security are not even making that much. So you'll be surprised what you may be eligible for. And yes, there is a 5-year look back when you're applying to Medicaid if you are over the income limit, the income federal limit. But if you are below that income limit, an attestation saying that you're below that income limit, you don't have to do that 5-year look back. Of course, Medicaid does their audits, and then if they see something, they will ask for it. But in our PACE program in Jersey City, we do have a Medicaid coordinator, and us and the enrollment team will help with that Medicaid process and kind of walk you through what's needed and help put everything together and work very closely with Hudson County.
Okay, thank you.
You're welcome.
So one of the things, and I think this would cover many questions, and Edgar, thank you for jumping on the chat and answering some of the questions, that if you do not have long-term care insurance, or if it's not covered by your Medicare Advantage plan, or the resources to pay for out of pocket, that one, you should talk to facilities such as what Lori pointed out, talk to the Adult Daycare Center if that would meet your needs, and to look at ways to finance it. But also people should find out if they are eligible for Medicaid. And the best way to do that for older adults is to start with your county office on aging. There's one in every county. So there's 21 in New Jersey. And also you can go to NJ211, either their website or I did hear that the phone line was down, but 211, you dial it like you would dial 911. And that has, it pulls together many resources and programs with one-stop shopping to help you find those. So if even if you're not sure, it is worth exploring whether you are eligible for Medicaid to pay for this. So are there other questions? If anybody want to put more in the chat or the Q&A, I know we've covered a lot, and I really thank you all for your comprehensive presentations. I think you probably answered all the questions as we went through. I think we have covered it all. So again, thank you for joining us. And I also want to thank our sponsors for this. I want to thank Parker and Springpoint for being our sponsors, AARP, Captel Relay, and Horizon Blue Cross Blue Shield for bringing this to everyone. We will be sending out the recording and slides to everybody who's registered, and I hope you can join us next week, Wednesday at 4 o'clock, where we're going to be talking about options for people when they need to leave the home, when it's time to find a new residence and a new living options for older adults. So I hope to see you all then. Thank you again and have a great night.
Thank
Bye,
you.
everybody.
Sure. Bye.